approximately 30 minutes, and we'll take all your questions at the end. So if you have any, you can put them into the chat panel, which is located on the right-hand side of your screen. And I'd like to thank you for joining us today. I'm Michele from SIMUL8 Corporation, and I'll be moderating this webinar. Joining me today is our SIMUL8 lead for healthcare, Cordeaux, Efficiency Engineers, Director of Health Systems, Barata. We're really excited about this webinar. We can't wait to show you how to bring your live value stream maps to life. I'm going to pass you over to Claire now, who's going to get us started.
Thanks so much, Raquel. I'm also very pleased to welcome you to this webinar. Just a little bit about my interest in this. My background is in healthcare and healthcare improvement, and I've experienced firsthand how powerful process improvement techniques can be. The simulation experience has also made me think that if we could enable process improvers to make their value stream map dynamic and allow them to test out their improvement ideas or future states in a virtual environment, then it could really help to provide some very good evidence for making change. And that's why I'm so pleased that SIMUL8's been able to produce a means to create live value stream maps. I'm delighted to say that Geisinger Healthcare has really been getting some benefit from this. Stuart, as Raquel has already said, is the man who's been making this happen, and I'm delighted that he's agreed to talk to us about his work and to show us all how it's done. So thank you, Dan, and I'll pass the session over to you now.
As far as most having at least a surface knowledge of value stream mapping, what it can do and where it's utilized. So we don't have the time getting into the depth of value mapping and its definition and theory, but we'll make sure that there's a little information around value streams that we all have a working knowledge of it as we utilize it in active environments of SIMUL8. One of the features of this webinar will be the actual use of the software as utilized in a project straight from Engineers Health Systems. And as Claire acknowledged, we appreciate the friendly folks that are letting us use one of the projects to illustrate this tool. So as time permits at the end, we'll be fielding questions throughout the webinar. As Claire all mentioned, free to add it into the chat session. We'll try to get to them during the webinar. If we can't get them within the time provided, then we'll definitely follow up via LinkedIn or direct email to you for all information. As a retreat here, as we get into the webinar, I thought it would be nice just to sneak preview of what this looks like. And the probably traditional view, the view most people are used to, is in the middle portion there, where we see the icons, traditional icons of value stream mapping and supplier through queue and process as an icon. But on top of this, we also have a ribbon at the top. And what it's going to help us do is that construct it with the drag and drop icons from the left. We can customize and really make the stream map. With that kind of manual customization comes our ability then to also monitor this stream in a number of ways. We'll give you that example on all the different types of analysis and monitoring tools that SIMUL8 now offers for this value stream mapping system. Step back just to make sure we're all starting at around with value stream mapping. We have a common understanding. We'll start with the value defined from a patient's point of view, and that's key. A lot of us, it's the work to understand how it was defined. And at one point, we were discussing this earlier, we would like to hear from our audience, because this value defined, it really kind of how we quantify these KPIs or key performance indicators, performance metrics, you might see them listed as well, use in your organization. So we use the chat we do. Key is to really understand that their patient flows through our process. What do they expect? That value proposition. And then the steps to identify that add value or waste. That is just getting the process to the point we all understand what's going on. In that process, true understanding from the issues as they enter our
because we have understanding, we'll just put that in that sheet. Right, and we'll go through that in detail as well.
If everybody could put their phone on mute. Sorry, Dan, let's just get this sorted.
So I'll put a thing in with the person's name, and if you could just jot the phone number in there as well, then we'll be able to get back with you as soon.
Okay, sorry about that, Dan. We just have some people getting in and not muting their phones. If you want to carry on.
No problem, Raquel.
You're welcome.
Waste is medicine or eliminated. Here is we need really to recognize the waste, and that get into a little bit as we categorize 8 main waste categories. We'll look in the presentation, but the idea is to minimize it and potentially eliminate it as best we can. And then the processes are improved and or standardized. And this through experiences, we know a lot of healthcare professionals may recoil at the thought of standardized healthcare. So it's important to press with it's not so much the traditional interface of that patient to caregiver, but it's really the operations and steps leading up to that interface and potentially trailing from it. You can all get that interface itself, but the idea is just to really look at the entire macro system itself and see where it does itself to standardization. A lot of people would be surprised of a lot of similarities, a lot of things that the uniqueness kind of disappears as we start breaking apart the process and steps. So, phases in healthcare. And here the those identify groups and families of care or service provided. And what that really is by what skill sets we may need for that certain family of care. It's not skill set or certain pieces of things of that nature. When we set up our value streams, we have many value streams for our organization, but we're starting off with a certain segment. As we zero in on what we're going to be looking at, we can start to then put those value steps together and define that current state. What's happening right now in our process, really understanding so we can start to piece those activities together. Only, what's going on in that process so that we start to manipulate and play toward our future or target state, where we get to. And a lot of this comes back to how we are quantifying ourselves initially. What we're saying is our performance portfolio is important to us. Whether it's a system for our patients, with the quality metrics we may have, where it is, we need to be able to define baseline that current state to where we want to get to. And then plan to change and improve from current to future state. All that is using this tool, that macro high-level view of the VSM, to focus our project team. Where do we have to do our work in the next several weeks or months as we attempt to improve our process? Where areas we need to apply some innovation to make our patient experience better, or other KPIs that are important to our organization. To try to interrupt, just a traditional healthcare value stream, very high level, where it's important is that patient entering the process, the process, the caring provided through discharge. Obviously, a lot goes into that, and so that the patient's needs are met. Along with a number of value streams that may come out of that for us, there are supporting value streams, care support being one. A lot of our supply chain activities fall under that as far as the movement of supplies, materials, equipment, things of nature. Also, administrative along with the billing processes that we have with our organization. And it's just a very high-level view of the value stream right now. The VSM current state really comes down to helping the entire team see the whole process and then identify problems and opportunities for improvement. And why that is very key is because working as project teams, we may have staff team with a number of different players who know different that process more intimately than others. So what it does is help the entire team have that whole view, so the shared understanding of what's going on from whom to in that process. Then, as a team, and that you can start to focus in on where the best opportunities are and where the most issues and problems are that we need to solve at this team. That problem is defined, again, we go back to what are defining and quantifying as an organization. What are our KPIs? Very important, can't stress enough, obviously, is how we're defining KPIs and how we define our measures of success. And that's way into how we're defining our measures of success. We see additional value stream performance matrix of measures, if you will. And what we do on the left-hand side there is process time being the first one. And in other words, process time that could be value-added time, if you will. That's the time the patient is actually interfacing with a caregiver, for example, when they're actually feeling that they're getting value from this process that they expected to get, they set out to get, entered the organization. Time is more around the realm of waiting, and either check out, waiting for when they're like that they're getting that value. And there's the combination of both. Really, the delay time together gives you that overall lead time the entire time that patient is spending in that process. You can see a metric called the added ratio. It's called a number of different things, but for the most part, that's looking at your overall processing time portion of the overall lead time. Again, trying to understand really the percentage of the time that person is spending in the process that they're getting value versus how much overall time they're spending in the process. And as we in the second column, we're starting from current state, and then we also tag our target or future state, which we get from playing that current state, understanding where we want to go, or just be given to us, but a lot like if they are future happens when we are manipulating a current state to see where we can get to. We mentioned the categories of waste, and in healthcare, as we've experienced in the past, most of the waste, or non-vet activities you may hear as well, can be 8 basic categories. Defects, which is the one that a lot of people are familiar with. It's the worst one. Production errors, surgical errors, these potential in revision, retesting, surgery is another one that obviously it's the worst because that is a failure of what is expected from a value-added activity in our process. So the value activity failed at that. You see overpressure, it's a duplicate art in multiple forms of the same information. We've seen this in organizations where we have so many forms, basically the same information, but they go to different areas. But we have allowed that same form or same type of information several times. Clinical staff does. So that overpressure is their way to reduce the need for that. Waiting for workers, needing surgeries, procedures, patients waiting for appointments. Because this waiting does not just affect patients, it also is affecting our clinical for operations staff. This, again, is helping us recognize where this is happening in our process. Or confusion. Some activity being performed in different ways by different people under priorities. We see this as well. The halls are going to emergency department. We see a lot of activity. Sometimes priorities are shuffled. And again, that has something to do with interpretation between us and a physician as far as what we done first, when we had to execute which orders. The idea is to work towards either a communication basis or some kind of standard operating procedure that limits or minimizes that confusion and adds clarity. Reporting and inventory waste. Those are most synonymous with our supply chain activities, but we're looking there to where things are stored, whether it's supplies, materials, equipment, and where things are stored, but how much of what is stored. So the idea is, again, trying to minimize that transport activity and also making sure we have the right amount. How many tongue depressors do we need on each floor in each house? Understanding if we're carrying 4 months of inventory or 1 month of inventory. Obviously, investigation entails a lot of analysis in regard to our replenishment programs, how much we have on hand. Motion, looking for information, materials, people, materials, tools get far from the work. and focus in on really our workstation design, really our examination rooms, where work is with the patient or in prep for the patient. And the amount of really we're putting our staff on searching for things where they could go to get it, understanding what is worked on most in certain areas. So what trips are repeated most often. Access processing, we see this in the reclaiming of orders, redundant information gathering, regulatory paperwork. You see this in a number of next signatures that we may see on a form. For all those signatures really needed, we see it's minimized a lot when processes have been upgraded technologically. But it still exists. It has been in existence for the last 2 decades. But there's software in place that prevents several steps or doesn't require those several steps to be in place to ensure regulatory issues within that process. So it's taking a step back, reckoning ways, popping your head out of the foxhole if you're looking around and seeing what's going on. And that's what these 8 categories and understanding what they are help us do in that investigation as we dig down into where the value stream is. So here, why did you tune in today? The benefits of the SIMUL8 dynamic BSM, it really comes down to a couple things. And it's that work your team, where around we put together that BSM, how the activities are playing off each other, we pray and see this thing run. And patients are queuing up in this process, understanding a little bit more of that activity and interactions that you have in that static BSM. And not that it doesn't have its place as far as the literature and post-it notes, there's still a place for that in getting ideas from our teams, but as far as this team, this itself, really energized. Because we know life is not average. We might have built into our VSMs, there's some variability that we can start to play with and start to understand in our process, which brings us to our future state and start to change some things around in a live environment, changing the process time, changing the tasks. We have some more complex ends that we need to move through. And then really understand how these changes affect our performance in a risk-free environment. To understand, okay, what KPIs are most important to us? Okay, fine, when we change this, that changes that. So again, it's seeing us highlight where we need to look for things, where we need to work next. And I'm sure we've all been part of teams where solutions, sometimes we come solutions on a gut feel, if you will. But what it does is it helps with the due diligence leading up to that project, solution section, which increases the probability of selecting the best solution. But several times, all done potentially with your project being looking over your shoulder, a very energizing exercise with the team. So that brings us to our actual example we'll be looking at today. And again, Geisinger, for those who might not be familiar with the organization, Geisinger is a 7-hospital, valid community-based health system, approximately 43 counties in Pennsylvania. They, through my experience and people I work with, an early and prime player in healthcare innovation, and they have invested greatly in their innovative operations and clinical areas as well. This project from the Women's Outpatient Center through their Quality Institute, which provides training and manages cross-functional project teams. And what we mean by that is these teams staff with not only clinical staff operations as well to truly involve all key players and stakeholders that process may touch and involve. Note here in the problem statement, you may have noticed it's a selection project that focuses on the return GYN patients. And return means here, as it sounds, it's returning patients, those who are not new to the system. We do not have to get new information, a new patient profile, if you will. So they are getting some kind of follow-up care or continuing care within this clinic. And noted, and the next line of information has seen patients on average take about 55 minutes or so to go through this process, and we'd like to move that closer to 35 to 45-minute time frame. Process boundaries or scope are patient check-in through patient checkout. And as we know here in the stakeholders, we see it is a broad set of stakeholders. So it's very important that if they're not on the team or representative from this group on the team, there exists at least a communication plan to make sure we have early and often communication as needed for particular groups. Okay. What we'll do is I'll flip over to our SIMUL8 environment, and using some of the information that was shared from the team's work, we'll put together their initial value stream. And again, traditional of our flyer, and in this case, that's going to ask us our patient entry. And what we said there about two patients per hour, so we will use a delivery frequency of 30 minutes, which gives us about 2 per hour. We'll then go to a holding queue. We use the icon for that. And here, we're going to wait for check-in. And as I drag drop these icons over there, I'm going to make this next spiral now with arrows. This here is check-in. And the time for that has been about 5 minutes. Do another next holding queue. They wait for an assessment. And then assessment activity. You drag and drop over the icons. I then have the ability to customize the ribbon up top. So along name, the average cycle time for that process has been 9 minutes. And the next one queue is a look for care. The only care provider. And then the process step. Care has an overall cycle time 10 minutes. And then one last queue, which is wait checkout. Yeah. 4 minutes. And then we'll take the customer on traditionally, and that will be act as our exit. All right, so did there. The benefit of walking our system, understanding high-level view of the stream. We can click above for us. It's a lot of stream map. Now you'll notice is the traditional data box that we've always filled in with static information in the past. When we can see that information changing. We should start to look at tips of information, especially the queues, as things see what the average waiting time might be for patients within those particular stops in the process. Now with the data analysis is now going to bring in our high-level analytics panel. And what this up a little bit for you. Ability to review our values in a number of different ways. First, the highlights tab on that panel. You have some default highlights that it's given us as far as where there might be bottlenecks in the process, where there may be a potential for utilization, which is highly utilization, as well as our activities tab on this run, giving you a view of how things are being utilized, whether it's waiting for work, it's working. Again, this is just used to the eye of the project team, or the action going on where we might have opportunities for improvement. Queues. As then we see the wait care, excuse me, the average of 7 minutes for that wait. taking information in. We're looking to think, okay, how can we potentially improve our KPI? We see patient exit time. It's about 52 minutes from our model. Now, at this point, I'd like to be close to what we've seen in our baseline information coming from our it may not be a minute-for-minute match, but you're looking for a relative changes in your processing model, VSM, if you will. So that's confident as you make changes within your model, you start to see what interpret kind of you would see in the overall process in real life. So, you note, I'd like to get that 55 minutes, if you will. In this case, 52 minutes down a little lower in that 35 to 45-minute range. We might initially into this come that wait for care and that care process. And initially, again, we're in the what if mode at this point. That overall cycle time average from 19 minutes, say it was 14 minutes. Well, due to that, we put in, we see what kind of results we get. Right, KPI average again, we see that that average time in the system is now 41 minutes. We saw a change that has for us. I believe we dropped 12 minutes in that overall time in the system by changing 5 minutes of potential process time in that one activity. Go back to and analyze how it changed for us as well. Understand where we are. We can see those times drop also. The idea here, though, it's not as simple as changing 19 to 14 to understand that, but what it does, what this is to do is drive focus of your team so that now to be that portion of the process first. That's where we potentially would see our biggest opportunity. If we're at that portion, it may not be the actual interface with our patients that the care provider is giving. What is happening around that activity? The care provider is spending time, even though the patient is there with them, are they reaching for things in that examination room? Are they charting excessively, things that maybe there's an easier way for them to get information into the system? That the team would investigate those and dig down to that next level understanding of that process. But all this value stream does is it gives us the ability to play, in this risk-free environment, the what if, to share this with other people as well, and the team. So, I'll back from this example a little bit here. Many of you are starting to think about all the possibilities you may have, especially maybe your more complex value streams where you have multiple paths that you might want to model here as well. That would help you do that. Help you, if you take out certain activities, there's joining of activities, whatever it is, there's opportunity and potential here for different possibilities of the use of this tool. Back to our presentation. Revisit the metric matrix, if you will. These are some numbers I populated with past iterations and use of this tool, where processing time or the value add time was 37 minutes. Late 20, giving us an overall time of about 57 minutes. And that ratio was about 0.65 or 65%. By making a change, which I just illustrated, we see that our processing time drops about 5 minutes to 32, which makes sense. Lay time, 11 minutes, which obviously it drops our lead time to 43. So our net value ratio moves from 0.65 to 0.74, the direction we want to move in. So what if it's a target? It's what the team works towards, but it's where we're going to work first, and that's part of the takeaways from this BSM and this project team. Is within that area that patients wait for care. It also shows that 5 reduction in that overall time, that representative of severity, if you will, of the patients going through the examination rooms and combination caregivers, bring that to about 2 minutes or so. That the teams are on to investigate the potential causes and then potential solutions in that area of the process. That's where the key to this is. What I keep you home with the history map is the level of view. It's that concept, well, for the project team, and where do we go first? And right open things up question, I just want to mention that I'm sure there's practitioners out there. This does enhance our Lean toolkit, but there's many things, assets that we really need to get a grasp on. And that is the resource use. And at the point, the value stream map is still that high-level view of noting the various steps in that overall process. To truly understand how resources are utilized in that process, we need to maybe take another step towards understanding basic simulation. And actually, it will be built in the next webinar that we'll be offering to understand resource utilization, to have the opportunity and the ability to look at features that offer greater investigative ability. The process interacts with not only the resources, but other writing and activities within that process. Another example we'll be utilizing, again, comes from our friends at Geisinger Medical Center, with the bed turnover process that was analyzed through simulation. And the idea was that people could be receive department because of community availability. So they really found some insights from it and had great success in performance improvement utilizing that simulation, which will be discussed next seminar. To turn things away, just let me quickly review what is coming through our chat boxes here.
Yeah, thank you so much for doing that, Dan. That was really, really good. We actually have a few questions that have come through. Are ready to answer those now?
Sure.
Hey, just one that's come through. It says, at what point in a typical lean implementation journey would you introduce a live value stream map?
Again, this is the age where we want to go with our improvement efforts. It's at the very beginning. As you're putting together your value stream, I start to get an idea of what those particular steps are. I get just a little information up front as far as overall full times, but that is an early on activity.
We have another one here. Does this tool help us minimize data collection and that we only need the process times and it provides the queue details?
Usually, it helps us minimize that data collection now. And as we need to dig down further, then we have efforts there. But initially, this is just something as a guiding light for us.
That's great. Just one more question, and then we can move on there. How can we handle efficiencies in value stream mapping?
The downtime, actually, within the ribbon, the simulate itself, simulate software itself, and I'll show you this. And too much detail we see across the ribbon. Obviously, there's a number of different options with this, but we do see a downtime percentage. So if, say, that particular process is dealing with a piece of equipment that we know there's some downtime related to, for what reason, take that into the software itself.
Right, okay.
And obviously make it more real.
Yeah. Great. Well, thank you so much for answering those questions. I think that's all we have time for right now, but if anybody has any questions and you want to put them through, we can either put them on the LinkedIn site, like you said, or we have the details here for Claire and Dan if you want to ask them. And then we also have the blog here as well.
Thank you, Raquel. Thank you, Claire, and everybody that joined in. I would just like to mention just obviously Claire at simulate.com. Myself, Dan Barata, at efficiencyengineers.com. So as we mentioned before, I would like to hear from you about your KPIs either through this webinar, but if you join us at our blog session at Simulation Healthcare, it's simulatehealthcare.ning.com. We'll find out there, and actually at the start is a string there, if you will, as far as understanding what type of KPIs you might be utilizing at your organization. Again, I think it helps everyone involved as we start to share this information with each other. And again, thank you for your time and wish you the best in your improvement endeavors.